everyone. Welcome to another episode of the AABIP podcast series. This is Roger Kim from the University of Pennsylvania, Perelman School of Medicine in Philadelphia, Pennsylvania, and I'll be your host for this episode. Thank you all for joining us today. Today we'll be discussing the nuances and complexities of how to define diagnostic yield for bronchoscopy procedures, a current hot topic in the field of interventional pulmonology. We are very fortunate to be joined by Dr. Anil Vachani today. Anil is the Director of Clinical Research and Professor of Medicine in the section of Thoracic Oncology and Interventional Pulmonology at the University of Pennsylvania and is an internationally renowned clinical researcher. On a personal note, Anil is also my career and research mentor and someone who serves as a role model to many of us early career professionals. Welcome to the podcast, Anil.
Thanks, Roger. Great to be here with you.
Before we dive in, Anil, do you have any relevant conflicts of interest you'd like to disclose?
Sure. I should disclose that I serve as a current scientific advisor to Johnson & Johnson as well as Intuitive Surgical.
Perfect. As a reminder, the views expressed on this podcast are those of the speaker and mine alone and not necessarily endorsed by the AABIP. With the formalities done, let's get started. Anil, in 2021, you authored a widely discussed letter to the editor published in Chest, examining the theoretical impact of various definitions of diagnostic yield for bronchoscopy. Your follow-up 2023 White Journal full-length manuscript found that diagnostic yield estimates can vary as much as 35% depending on the definition used, and that cancer prevalence significantly impacts diagnostic yield estimates. As a result, the joint American Thoracic Society and American College of Chest Physicians 2023 consensus statement on diagnostic bronchoscopy diagnostic yield recommends using a strict definition of diagnostic yield, incorporating only malignant and specific benign findings in the numerator. Anil, can you take us through the initial rationale for your studies and what major takeaways are regarding the importance of how we define bronchoscopic diagnostic yield?
Yeah, sure. It's certainly relevant to our field, right, to read studies of bronchoscopy and diagnostic yield. I've been reading them since I was a fellow and trying to understand what the landscape of, at least at the time, what endobronchial ultrasound or even navigational bronchoscopy offered as an advantage over traditional fiber optic bronchoscopy for diagnosis. I had never really thought in great detail about the nuances of calculating diagnostic yield. I suppose that I read the results and to some degree made assumptions that the authors were really using some tried and true method for calculation of diagnostic yield. And oftentimes, we sort of skip over those methodologic details and jump straight into the results. And as you know, some of the early results from studies of diagnostic yield that were more single center based suggested improvements in diagnostic yield of navigational bronchoscopy over traditional bronchoscopy. And there probably wasn't until the Acquire study that was published that used a stricter definition at the time, and that suggested lower diagnostic yield in clinical practice that I started to think about it more. And then I of course was working with some colleagues at Johnson & Johnson as they were thinking about how to conduct their study, their single-arm diagnostic yield study on the Monarch robot, and wanted to dive into a collaboration really more around the methodology of diagnostic yield calculation. And as we looked into the literature, I was really shocked by how very different methods were being used, that individual investigators would consider different results from bronchoscopy, largely around the benign findings, right, the non-malignant findings where we know that we can see a whole host of results around findings that are not necessarily specific for a benign diagnosis and sometimes, frankly, non-diagnostic, and how those are considered so differently in calculations of diagnostic yield, and ultimately resulted in very different answers around diagnostic yield that I thought could very much influence my behavior on choosing one device versus another, or even my decision to buy a device for my institution. And so that's when we decided to make it more of a quantitative, thoughtful approach and published our letter in Chest, which, as you know, showed a pretty large difference in diagnostic yield depending on how you do the finer details of the calculation.
Yeah, I mean, I found that it's one of the most often brought up studies, over the past 3 years ever since it was published, and really, like you mentioned, focuses on the nuances and when you do not have malignant findings on pathology. I think we can all agree that a true positive is always the case whenever you have a malignant diagnosis, but pretty much any time you have a non-malignant diagnosis is where some of the kind of gray zones and uncertainties start to creep in.
Yeah, no doubt about it. I think that, I feel like people somehow believe that we know for sure when we have a benign diagnosis on bronchoscopy, and I think that's partially influenced by our own pretest probability. We know when a lesion looks a little more benign than more likely to be malignant, and then we want to believe that non-specific inflammatory result that we get back is truly a specific benign. But if we hold ourselves to, I think to firm ground around definitions, which I really believe that's sort of the key to all the work that we do. We need to define what we're doing and apply the methods in a rigorous fashion. That there's only a small handful of diagnoses that we get that are truly specifically benign at bronchoscopy. A lot of what we find is non-specific, and we need to have rules in place to be able to categorize those when we are evaluating our technology.
Yeah, such a great point, Anil. I'd like to kind of dive in a little bit more into some of the details that we've already kind of started to bring up. And that's this concept of how we even categorize positive versus negative findings. So the ATS-ACCP official research statement notably makes a distinction between diagnostic yield, which is an estimate of the ability of bronchoscopy to guide clinical care, and diagnostic accuracy, which refers to the ability of a diagnostic test to identify a specific disease entity, such as lung cancer, and by definition also requires establishment of a gold standard reference. Can you help our listeners make sense of these important differences, which may at first glance seem like a semantic nuisance?
Yeah, it's funny you use that terminology, because to me, when I first read it, as you know, I'm not a co-author on the statement that was put out by the ATS and ACCP, though they do refer to some of the work that I did. I was also unsure of exactly what distinction they wanted to make in this regard. But as if you read it carefully, I think they make a very important point, right? That diagnostic accuracy really uses the classic definitions that we know about from statistics and epidemiology, right? Sensitivity, specificity, negative and positive predictive value. Those are terms that we are tried and true in the diagnostic field, that we know that they should rely on a gold standard, that they are largely simple calculations that are really based on a single diagnosis. The concept of diagnostic yield has really evolved, I think, more recently, and it's not one that's actually all that well defined in the literature by statisticians or epidemiologists, because it's an evolving concept. It's an evolving concept because we've only recently learned to think about how our results of our tests, bronchoscopy in our case, influence decision-making downstream. And I think they've made a nice distinction that we should present accuracy results using a gold standard for a specific diagnosis, usually using malignancy as sort of the reference that we wish to understand and categorize. But diagnostic yield is a little more nuanced. It is the concept, as I think of it, and as stated in the statement, that we are getting information that's going to influence how we manage the patient. It may not necessarily be that we are no longer going to do any more imaging and consider something benign. We may still need to surveil a patient. We may need to treat an infection. We may still need to treat something surgically that might be benign, depending on what symptoms and issues it's causing. But it allows us to make a clinical decision based on their result. I think that's the key distinction that I really admire now that the folks who were involved in the statement were able to sort of tease out. And I think it is the path forward for how we view this literature going forward.
Absolutely. And, kind of riffing off of that, there's been a number of studies published by folks such as David Ost out of MD Anderson and Fabian Maldonado out of Vanderbilt, looking at the distinction between using only the index bronchoscopy results as opposed to incorporating, as you mentioned, follow-up testing, months of imaging serially done subsequent to the initial bronchoscopy, to incorporate that data into our ultimate assessment retrospectively, adjudicating whether or not a bronchoscopy was of quote unquote diagnostic value or not. And I think once you kind of go down that rabbit hole, it gets very confusing very quickly. I guess just to refocus our discussion back to where we started as far as the strict definition that you initially proposed in 2021, it sounds like, that's really focused more on just using those index diagnostic bronchoscopy results. Is that right?
That's exactly right. Yeah, we should clarify that, right? So I think that most people, as you suggested, have come down to believe that using the strict definition, which essentially uses true positives, those that are identified as cancer on bronchoscopy, and true benigns, specific benign diagnoses that we can act on as the two categories that should be included in the numerator, with all bronchoscopies being in the denominator as sort of the simple calculation of strict diagnostic yield. It is perhaps the method that is most straightforward and perhaps most comparable study to study. We can come back to prevalence of malignancy in a moment, but it is the one that takes out the complexity of follow-up time, patients being lost to follow-up because we almost never have 100% follow-up in bronchoscopy studies, and the influences that those factors have. If we're going to compare technology to technology from era to era, I think the strict diagnostic approach to the definition is probably the most appropriate.
Makes complete sense. And you already alluded to it, but this concept of cancer prevalence. So one of the major findings from your work was that cancer prevalence is a crucial factor to consider when evaluating any diagnostic bronchoscopy study's report of diagnostic yield. In your 2021 CHEST paper, you found that only approximately 10% of all pulmonary nodules greater than 8 millimeters in diameter were malignant. As interventional pulmonologists become more and more confident in their ability to navigate to smaller and smaller nodules in the periphery, it's reasonable to expect that the overall prevalence of malignancy may decrease in future diagnostic bronchoscopy studies. This could result in a paradoxical decrease in reported diagnostic yield of newer technologies, especially if, as you suggested, the strict method for diagnostic yield calculation is consistently used as recommended by the consensus statement. In these dynamic times, how should interventional pulmonologists make sense of future studies on diagnostic yield?
Yeah, it's a great question, Roger, that you've raised. And I think that the work that's been done in the field so far has raised the issue of prevalence of malignancy influencing diagnostic yield. I don't think it's yet offered a solution, nor does the statement from ATS-ACCP yet offer a solution for how we think about this. I agree with their recommendations that every study should report yield, accuracy, and prevalence so that we can, at the very least, be as transparent as possible in understanding the underlying population and then assessing what diagnostic yield means in that context. I do think that there's an opportunity for more work here, in fact, right, that we should think about how, if we are going to see large differences in prevalence in diagnostic bronchoscopy studies going forward, how do we think about maybe something like an adjusted diagnostic yield, right? That there are concepts that I think that are still meant to be worked out in this area. I don't want to make it more complex than it is, but I do think that we still need to get to a place where we really feel comfortable as a society and the community for how we think about judging new technology. And frankly, this all comes from the fact that I think that there is some over-optimism as new technology comes out, and I don't know that optimism is always warranted. Certainly some of the newer technologies appear to be performing quite well, but we want to be able to look at those technologies and judge them with as straight an eye as possible, right? So.
Absolutely. And just to kind of maybe say what we've been kind of alluding to out loud, any given interventional pulmonary practice may have a lower or higher threshold to perform diagnostic bronchoscopy, which will then, by definition, result in different malignancy prevalences in published cohorts. For example, if someone is going to have a very high bar to want to do a diagnostic bronchoscopy until the risk of malignancy is, say, 50%, you might have a very, very high malignancy prevalence in your cohort, whereas if someone's going to be a little bit more aggressive in biopsying smaller nodules that might have a lower pretest probability of malignancy, you can imagine malignancy prevalences as low as 10, 20%.
Yeah, I think that's certainly a potential influence. It is my impression from the field. This may be slightly off topic, but it's my impression from the field, having been on LinkedIn just a couple of times, that there seems to be a fair amount of positivity towards existing technologies and going after smaller and smaller nodules. And I would hate for, like individual case reports of success influencing how we behave. Ultimately, again, I think that this is slightly outside the topic of diagnostic yield, but we still want to try and target our bronchoscopies to patients who, have some reasonable probability of malignancy and some reasonable probability of success of the procedure. And so it's my hope that the prevalence will stay largely stable, and that will still allow us to compare diagnostic bronchoscopy studies over time. But the other interesting thing is that if we do see a change in prevalence of malignancy over time, that may be saying something even larger about our field than just how good we do at bronchoscopy. So.
Absolutely. There's always that concept of confounding by indication, and how that bias may change over time is certainly going to be interesting to see how that plays out. For our early career professionals, listeners who might be interested in getting involved in IP research, assessing novel technologies, what advice or guidance would you provide them?
Yeah, it's another good question. And obviously, the field of IP is growing rapidly with, many new programs, many new trainees, but much new opportunity available, right? My simple rule for research is, it's simple. It's find a good question, right? Keep your eyes and ears open. Listen to as many presentations as you can. Read as many journal articles as you can in the space, and understand what a good question is that still exists, right? Try and distinguish that from repeating something that's already been done 20 times and may only be an incremental advance in the field, to looking for questions that really remain unanswered. And then go for it, right? Ultimately, figure out what an interesting question is, get good mentorship, and learn how to begin tackling the problem. My own experience here notwithstanding, right? This article in Chest that we published 3 years ago that sort of started this little area, or at least continued this little area, was really a very simple idea, but one that had really never been answered in the literature, and one that really wasn't even all that complicated to do in terms of analysis, right? It was, I think, just a good idea at the right time, and I think that's what our mentees need to learn, right? The best idea at the right time for our field, and then knowing how to jump in take small steps first, do some preliminary work, generate a little bit of data, and then learn how to build and build and build upon that to do work that hopefully will influence how we all practice.
Well, certainly words of wisdom that I think everyone can benefit from. And you certainly are a guiding example for a lot of us in the field. Time for closing remarks. Anything you feel we left out that is important to discuss?
Well, yeah, I think I alluded to this one also, but I think that the ATS ACCP statement is a really good statement. I think that the authors that I mentioned did a very thoughtful job around this particular issue in diagnostic bronchoscopy. But I sometimes wonder whether statements like that almost appear to some to be closing the door on needing further work. And I actually think that there's a lot of work that needs to be done outside of just the definition of diagnostic yield. We have a lot to do in our field to learn how to evaluate new technologies. And we are, of course, being, to some degree, bombarded with new technologies all the time in our field, because so much innovation is going on, largely in the commercial space, but also in the academic space. And so I think that we should really use this opportunity to fine-tune and harden our methods for how we're going to do this work, outside of just diagnostic yield definitions, but how study design, procedures, analysis. This is a wide open space in our field, and a real opportunity for the young investigators we just talked about.
That's such great advice, and certainly the future looks very bright, and lots of research questions to be answered, and hopefully a lot of great research to come over the next couple decades. Well, Neil, thank you so much for your time. We know you're very busy, and I know I certainly learned a lot from you today, and I'm confident that our listeners have as well. So thank you very much for joining us.
Great to be with you, Roger. Thanks for the invitation.